Hi, everybody. Thank you so much for joining today's session. We are pre-health shadowing, and today I'm here with Dr. Benjamin and our volunteers, Kieran, Kim, and Irabor. So let's start off with a quick presentation about what PHS is, and then pass it over to Dr. Benjamin. Okay, so once again, thank you so much for joining Pre-Health Shadowing. We are an international student-led nonprofit for medical advancement. So throughout this session, we have closed captions available to accommodate the needs of all students. And if you have any other ideas on how we can be more accessible, just feel free to email us at info@prehealthshadowing.com. Other than this, if you want to stay up in the loop, you can always sign up for our email list, and our audience engagement lead is going to be posting all the details in the chat. And other than this, here are our social media handles. So we love to know where students are calling over from. So I'm based in San Jose, California, and feel free to type in the chat where you guys are calling from. Canada. Oh, wow. New York, Washington, Boston. Pretty diverse group we've got here. Thank you guys. Other than this, if you're interested in being part of the pre-house shadowing team, you can register as a volunteer on our website today, and it's 100% remote, so you can do it from the comfort of your own home. And other than that, we're also recruiting for our leadership team, which is also 100% remote, and you can apply online today with the link in the chat or the PHS website. And here are some of the available roles. But also, this is not limited, so if you think that there's another role that would benefit the BHS team, you're more than free to suggest roles. If you are a high school student, well, good for you. We have our HTV program, which is offering leadership and healthcare education for pre-college learners. And for this, you can just fill out the interest form on the chat or on the website. Once again, donations are the base of pre-health shadowing, and it would be really great if you guys could donate, even if it's like $1, or you can also donate by giving your valuable time with us through volunteering. Throughout this session, you're going to have the opportunity to ask questions to Dr. Benjamin, so feel free to type your questions in the chat, and our co-host or Q&A lead will ask them during the Q&A session, which is like the last 45 minutes. Make sure you take good notes throughout the session because we're going to have a post-shadowing assessment available where you can get a certificate verifying the hours that you dedicated with us. And it would be really great if you guys could turn on your camera because we're trying to replicate a real life scenario and it just makes the session more engaging. So now I'll just pass it on to Dr. Benjamin and you can take it from here.
Hi, everyone. Thank you very much for having me. Let me start the presentation. So I'm going to do a couple of things tonight. First of all, I'm going to um, talk a little bit about my career and how I got to where I am. And then the second thing I'm going to do is I'm going to talk a little bit about public health and kind of give you a sense of what the public health system looks like and give you a sense of what I do there. So just starting that, I don't have any financial conflicts with today's presentation, um, but I do have a presentation bias. And just so you know, I'm very much pro science. So growing up, I always knew I wanted to be a scientist, but no clear idea that would be. Like a lot of kids, I looked at botany and chemistry and biology and physics. I wasn't very good at physics at all, but I kind of knew I wanted to be a scientist, but again, no real idea what that meant. Um, so when I went to college as an undergraduate, I went there to get a good science background. And while there, I was doing some working in a guy's lab, um, and he was a MD, PhD doing some sickle cell research. And I was frustrated that I just didn't know enough. And with that, I went to medical school to get an enhanced medical science education so that I could do molecular genetic research. Frankly, I had no interest in clinical medicine as a career. That wasn't something that I had really thought about. But while in medical school, I absolutely fell in love with clinical medicine and emergency medicine. Now, my move to public health was primarily a management and leadership opportunity, which you can talk about. And note that I was very early in the beginning of emergency medicine as a specialty. So that's why I trained in internal medicine and not emergency medicine. So you can see from the bottom up that I went to Illinois Institute of Technology, which is an engineering school. So I took lots of sciences with the engineers. I then went to the University of Illinois College of Medicine. Um, and then the Army paid my way to medical school. So I did an internship and residency in San Antonio, Texas at Brooke Army Medical Center. And interestingly enough, I was an intern or PGY1 in the first rotation I had. And I was there when the Army opened up his first emergency medicine residency. And my faculty advisor was the guy who put together the training programs for emergency medicine for the Army. So I was kind of lucky in that I just fell in love with it in medical school. And then in my residency, um, I was highly exposed to emergency medicine. Um, so in the military, I did some training. I took a lot of the military courses. I originally planned I would stay in the military I wanted to be a general. I was going to stay in the military for over, you know, 25, 30 years was my original plan and practice medicine there. We can talk about, I changed my career a little later in my life. Um, but I also got some specially educational training with public health, or something called the Public Health Leadership Scholar. I did what was really a 1 week leadership program at the Harvard Kennedy School of Government. And I was a fellow for 6 months, did a sabbatical at Hunter College, where I was a distinguished fellow in public health at Hunter College. You can see that I carried all the traditional medical licensures as well as being boarded in both internal medicine and in emergency medicine. Once you get boarded in internal medicine, when I trained, you got boarded for life. In emergency medicine, you have to take your boards every 10 years. And so after the first degree of certification, I had stopped practicing emergency medicine and was in administrative medicine. So I let my boards lapse. Um, you can also see that I was invested in military medicine, high ROTC in high school and college. Again, I had a scholarship to college in medical school. And in medical school, I was in what's called the Health Profession Scholarship Program, which paid really a full ride to medical school, um, tuition fees, books and supplies, and $400 a month. And then I was on active duty. While I was on active duty, I was considered an active duty reservist from 1978 to 1987. But as you can see, I wore a military uniform from most of my adolescence and adult life. And I certainly was an active practicing physician, practicing at in the military from 78 to 87, and then in the private sector in many places. And I actually had my own emergency medicine group for a few years. My military career, right after I finished my residency, as I mentioned, when I finished my residency in internal medicine, I had a chance to be the faculty at the Madigan Army Medical Center in Tacoma, Washington. And then I was chief emergency medicine at the Walter Reed Army Medical Center for 4 years. And then after getting out, I went to the District of Columbia, where I was chairman of the Department of Community Medicine and Ambulatory Care. Um, I was there for about 2.5 years, and then my phone rang, and the mayor was on the other end of the phone, and he um, was called me and asked me if I wanted to be the health commissioner in Washington, D.C. So I was what health commissioner in Washington, D.C. for almost 2 years. And go ahead. The record looks like okay. Um, and was I left and went to the health department in in DC for almost 2 years. And then I left and went and practiced emergency medicine for about 2.5 years. Um, Let me get my slides back up. There we go. And then I was asked to come back to the city, and I ran the ambulance bureau, basically chief of EMS and a deputy fire chief for the fire department in Washington, D.C. Interestingly, that was one of the busiest ambulance services in the country at the time. And I did that for about 10 months. And then I went to Maryland, where I served as the deputy secretary for public health services for about 4 years. And then I became secretary of health again for about 4 years. So I was at the health department total about 8 years. What's important to know is that when I went to the state of Maryland, I couldn't practice medicine. The lawyers wouldn't let me. We regulated so many things. There was a conflict of interest. So it's at that point that my active clinical practice started. I'm sorry, stopped. You can see I had some activity in the private sector. I mentioned my company that I ran that actually practiced emergency medicine. I served as a health policy consultant for about 4 years. And now I'm at the American Public Health Association as the chief executive officer. And I've been there now in my 24th year. Um, and then to give you a sense of what I do as APHA, I serve there as the chief health strategist, where I promote national health policy. It's a $26 million company. I do fundraising. I serve as a chief national spokesperson. I'm the publisher of a newspaper called The Nation's Health. We have a small book company and the top journal in public health called the American Journal of Public Health. We do a lot of education. And of course, it's a membership association, so I engage our members and supporters. So with that kind of background of my history, let me talk about what public health does each and every day. Um, and I think the challenge for the nation is to really build the public health system for the future. We're going through a lot of innovation, new ideas, new diseases, and so public health has a very, very bright future. But the system was not designed or resourced to meet the strategic needs of the nature. It's really a patchwork of programs and funding streams, and in particular, our emergency preparedness also developed over time through an episodic series of funding streams and programs that have not really been sustained. Public Health in the United States is a federal, state, local, and territorial partnership with uses civil society as a part of the system. So that means these nonprofits. And interestingly enough, that governmental public health is the only entity that has the legal responsibility for the health of the community. Your hospitals, your doctors, they do not have that legal responsibility. They have a legal responsibility to do their work well, but at the end of the day, they're not legally responsible for the health of the community. It is governed locally and managed as a partnership and relies on strong relationship with nonprofits to do their work. So these are examples of several of the nonprofit organizations like APHA who do the work that they do. Um, State Health Officers Association. There's Association of Local Health Department Directors. There's a National Association of the Laboratorians for the public health labs. Certainly specialty groups like CSTE, which is for epidemiologists. There's even a foundation that was established by Congress. And of course, the American Public Health Association, which is the umbrella organization over the whole nonprofit sector. And what these nonprofit organizations do is they build support and enhance the capacity of what the governmental public health organizations do by doing education and advocacy. They help with policy development. They build the workforce, including accountability things like accrediting schools and programs of public health, having scientific meetings, enhancing research, leveraging what the federal government does in the private sector, helping people with careers and networking. And we have several accountability groups, including the Board of Public Health Examiners, which basically certifies people who get degrees in public health, and the Public Health Accreditation Board, which actually accredits the health departments in the country. Now, public health operates in an incongruent fiscal environment. Something bad happens, and then the federal government or the state government adds money, usually not enough and too late. And then the expectation of performance far exceeds the funding, which is a real challenge for public health. The United States spends $5 trillion on health between the public and private sector, and public health spends only about 3% of that is for public health. Now, the basic work for public health, this is called the 10 essential public health services. And you can see that it really falls in three buckets where we do assessments, looking for new and evolving health threats, crafting and implementing solutions to those health threats, and then ensuring that it gets done. Now, we don't have to do all this stuff ourselves, of course. We work with others to make sure it gets done. Obviously, there's a huge private sector healthcare delivery model that we have out there. But where they don't do things, the public health system fits in. So, for example, working with animal control programs or sexually transmitted disease programs where we need to focus in targeted ways, or certain specialty infectious diseases. So like when we had the COVID outbreak, that was a national emergency, and the public health system had to augment what was happening in the private sector by making sure that we had a test for the disease, that we could provide policy for who got vaccinated. And in fact, the private sector and the government partnered on making a lot of the vaccines for COVID. Now, a lot of things have changed over the years. We're now having to deal with multiple epidemics at the same time. Science is evolving very quickly, our knowledge base very quickly. And we saw that with the rapid application and discovery of RNA vaccines and some of the therapies we used for COVID, which were um, really designed in a very, very fast manner. We also know that we have an aging population. We in medicine do a lot of things to people that potentially make them very sick. You know, in order to cure people with cancers, we treat them with anti-cancer medications, which lowers their immune status. If you have an allergy, we put you on high-dose steroids, which lowers your immune status. So we ultimately put people at profound risk as we work to cure them from other diseases. Social media, the internet, now drives human behavior in an extraordinary way. And there's a great deal of misinformation and disinformation out there. A lot of disruptive technologies. On this picture, you see in the lower right-hand corner, vaping. Just as we were finally getting our hands around combustible tobacco, now we're having to deal with vaping as a risk for addiction. and the risk, of course, of some of these things that people use with vaping tools can help destroy their lungs, cause cancer. Um, we used to be very invisible. Now public health is very visible. There's a growing distrust of expert advice in science, which is a real problem right now. Um, the misinformation and disinformation is called an infodemic, and public health has become overtly very, very, very political. So the ideal system that we want to create for the future is one where every public health person sees themselves as the chief health strategist for their community, meaning they see themselves as responsible, that if it hurts people or kills people is there, that they work in an agency that's structured to deliver the 10 essential services I showed you in that chart, that we have timely, actionable data systems. Tragically, we're still sharing information by fax machine because we haven't built a national data information highway yet, even though the technology is there, and even though other countries around the world have rapid, fast data systems where information is shared, at the speed of electrons. We have to do a better job of harmonizing the legal authorities across jurisdictions. There's a lot of patchwork about the legal authorities for public health departments. We have to make sure we get adequate and sustainable funding, that we work more proactively and with the private sector, and that our accreditation systems are make sure that we're more accountable. I also think the next generation public health system will fully integrate both public health and healthcare data systems, that, again, we can rapidly track and evaluate pathogenic organisms using next generation genetic tools, that we have robust systems to forecast diseases so that we can track where diseases are going. So like right now, we have over 20 states with substantial measles outbreaks, and we really aren't ahead of that outbreak. We're chasing that outbreak. We need to have a workforce with new skills, which I'll try to talk to you about. And we've got to improve the trust in science and government if we're going to improve the public's health. And we have to improve the public's understanding of science and medical literacy. And then health equity is the fundamental to what we do in public health. We need to have a system in which everyone in and nobody out, and that everybody's able to achieve their optimal health and have that opportunity. So if we could create such an integrated system, it would address any health threat, whether it's emerging or re-emerging infectious disease, chronic diseases like heart disease, lung disease, kidney disease. We could address the challenges of climate change and severe weather, product contamination. There's over 1,400 active foodborne outbreaks today that are being addressed by the Food and Drug Administration and CDC. And nowadays, products come from all over the world, and the components, whether it's food or product, come from all over the world. So the risk of contamination or product not working as intended, particularly from a safety perspective, is enhanced. We still have significant epidemics of injury, both intentional and unintentional, and obviously firearm-related violence is a major part of that. Falls, particularly in adults, is a major problem that we have to address. And while we've done a substantial improvement in automobile crashes, that's still a big issue, particularly in the global world. Terrorism continues to be a risk, and toxic exposures, particularly from cars and power plants, which exacerbates our environmental exposures, but also makes climate change worse. And these are some of the skills that I think that the new people in practicing public health need to have. As we move into the new world of genetic molecular technology, we need to be more skilled at that. I mentioned modeling diseases, data science skills. We've got to get better at being political in scientists, not partisan, but good political scientists, because political science is the art of convincing people that your perspective is the right perspective. Um, what we call meta leadership, which is the idea of leading people who you don't necessarily control, they don't work for you. It's about managing and influencing people that you have to work with who are in other disciplines and other sectors. Engaging in private sector, working in a collaborative manner is an unnatural act. People don't do it very well. So it does require a skills to do that. We also have to improve our skills in diffusing conflict and becoming a regulator. So when I first got into public health on Friday, I was ER doc. I got appointed to the health department that next Monday. And that Monday, I was suddenly a regulator. I had no training in being a regulator. We've got to do a better job of training people to be regulators as part of their basic training in public health. And then, of course, communicating, risk communication, helping people understand risk. We human beings are not very good at risk assessment. And of course, skill that you younger folks are very good at, as older folks are not, utilizing the internet and social media. And of course, advocacy. And that's the idea of engaging the public and elected officials to put out your perspectives. The United States has a huge health agenda on the plate right now. This is to give you some of the list of things that we're dealing with. We have reversing significant declines in life expectancy. The health system is becoming unaffordable. We don't have a system with everyone in and nobody out. Addressing the social determinants of health. 80% of what makes you healthy occurs outside the doctor's office. It's access to food, housing, safe transportation, um, adequate income. All those things dramatically improve your health. Certainly, um, we have a baby boomer population that's aging. A lot of dementia and Alzheimer's disease that's out there, and we're not prepared yet to deal with that. Food insecurity, which is going to get worse. Food safety. I mentioned the number of foodborne outbreaks already out there, and I mentioned our issues around tobacco control. We have a growing mental health crisis exacerbated by people being isolated with COVID and the overutilization of social media. Um, Chronic diseases continues to be a big issue. We're learning a lot more about cancer, and our tools to screen and intervene in cancer um, are really quite successful, and we need to do a better job of that. We also know that there are vaccines now that are anti-cancer vaccines that we need to use in a much more abundant manner. We've got growing workforce shortages, partially because of burnout, aging, and the fact that we really haven't built a robust health workforce. So your future is bright if you're going to go into health. Trying to deal with the health inequities. Just the other day, we found out that maternal mortality is improving a bit, but we still have huge disparities, particularly among women of color. And the fact that on any given day, we're dealing with the opioid epidemic, the obesity epidemic, and maternal mortality epidemic as examples. We've got significant problems with climate change and other environmental issues. Our central cities, the water pipes were built with lead-lined water pipes. So the things that we saw in Flint, we're going to be seeing more and more in all of our central cities. The good news is the Biden administration had funding and a program to replace all the lead line water pipes in the country. And the Trump administration has continued that process. I mentioned the issues around injury as a big problem, particularly gun violence and falls. And interestingly, pedestrian injury. People who are walking, not paying attention, are becoming a major problem in our particularly our urban settings. Lots of infectious threats. I mentioned return of diseases like measles, because people have lots of vaccine hesitancy, and that's growing. Diseases like pertussis, that's whooping cough, where that vaccine does not provide lifelong protection, and so you have to make sure you get revaccinated at a certain periodicity. We know that we have a sexually transmitted diseases are up, and because of climate change, we have a lot of vector-borne diseases. Those are diseases that are passed on by insects, and so things like Lyme disease and malaria in communities never saw it before because the environment is changing and the infectious organisms in those areas are changing. And things like bird flu, which has now moved from birds to our cattle, which is impacting milk. And we're having more and more people who are not drinking pasteurized milk. Um, and that's a big problem. I just want to point out two diseases that we really have our hands around. We just need to do more. Number one, HIV/AIDS. I came into public health during the HIV/AIDS epidemic when we didn't know what HIV was. We now know what it is, and we can, at this point, totally control it. We have the capacity to totally stop transmission of HIV/AIDS, and we've now converted it under proper therapy to a chronic disease. People used to die routinely from HIV from AIDS. Hepatitis C is also an unknown disease that causes liver disease and then eventually cancer. And we have now had the capability to totally control and cure hepatitis C with just a few pills. Um, COVID's not gone. Just want to let you know it's still around and it's still an infectious threat. And tragically, we've had some distractions of what I believe is a sound health policy. We have people, even at the federal government level, who are limiting fluoride in our drinking water, limiting access to vaccines, unfunding many of our federal agencies, and firing people indiscriminately. They're using our data systems inappropriately, limiting access to care, reducing our global health engagement. In fact, in closing agencies like the USAID, which did an amazing amount of um, safety around the world. And the president's tariffs are beginning to impact global health goods and services. And we haven't seen the full impact of those tariffs yet on the health side. Now, there's an opportunity for us as civil society organizations to engage more effectively. So APHA, as government begins to withdraw from things, organizations like mine are more engaged in activist work. And we've created something called the Campaign for the Public's Health, which anyone can be part of. And it's our effort to promote good health in every community. Um, and this is our advocacy strategy, is make sure people follow the law, to make sure it's transparent so people understand the impact of bad policy. Um, and what I do is resist anticipatory obedience. One of those things is that there's an effort now to redefine terms like diversity, equity, and inclusion, and try to make it sound like those things are reverse discrimination, which they're not. Diversity means making sure that you have um, a diverse workforce, a diverse program, that you have the right people involved in all your programs. Equity certainly means that everybody has an equal opportunity to achieve the best health outcome. And inclusion, of course, means sitting in a room and asking who's not in it, who doesn't have a voice, and making sure they get their voice. And equity, diversity, and inclusion are core values that my association has. And we guard that regardless of the people that we think will be opposed to us. So with that, let me thank you, and I'm happy to take questions.
Gabor, I'm gonna pass it on to you. Ooh, okay, I think he's not here, so I can ask the questions right now.
Afternoon. Um, I,
Oh, okay.
oh yeah, I was gonna. Okay, so I took down a few
Go
questions
ahead.
from the chat. What do you see as the most urgent global public health challenge in the next 10 to 20 years, and how should future health professionals prepare to address it?
Oh, thank you. Yeah, so the question, of course, about what's the most pressing global health problem. You know, I still think that making sure that everybody has access to health care is a major issue, and that we build the infrastructure um, to make sure that happens. So, for example, there are just so many places in the world which don't have good road systems. They have terrible educational systems, and those people cannot take advantage of the health systems and the knowledge base that we have. So you have people that can get that information on the internet, but they we can't get those systems to them. We can't get vaccination systems to them, et cetera. So that's a big issue. I still think that discrimination and both by class and race remains a big problem worldwide. And then, understanding that infectious diseases, chronic diseases, road injuries, all those things are things that are, you know, things that happen because they're technological achievements that we have. Tobacco continues to remain a major issue outside the United States. We've had enormous success in the US, but the tobacco industry is still robust in other nations outside the United States.
All right, thank you. Next question. What are some things that can be done on small and large scales to restore trust and belief in science and medicine and to bridge the gap between those that are science literate and those that aren't? And from your experience, is this a uniquely an American issue or are other countries struggling with this as well?
Yeah, everybody is struggling with the misinformation, disinformation. You know, nobody knows when you look at Facebook or Twitter or whatever, um, sometimes even YouTube, nobody knows what's real. So the big issue we have is how do you validate and what are trusted sources that you can go to? Um, the best way to get trusted information is to flood the zone with good information to start with. Trust is easy to lose and hard to gain. And I would argue that what we need to do is give people the best advice that we can and build trusted messengers. So you build that trust relationship with people by engaging them, by them seeing that every time you talk with them, you're giving them the truth. I'll come back to what truth means in a moment. And at least your best understanding of that evidence and knowledge. And then you're going to make mistakes because we're all human. You own up to it. You say, look, I made a mistake. I said the wrong thing. And, correct it and move on. That's going to be very important. I believe that science is the quest for truth. And so when we say trust the science, we're telling people to trust the scientific process, that science is an iterative process that changes, our understanding changes over time, and that we give people clearly what we know. We're real clear by telling them, this is what I know today. And I might know something when I get more information tomorrow. And so you reiterate, yeah, what I told you yesterday was based on this understanding. And now I have this new knowledge. And here's how I'm modifying what I told you. So let me give you an example of that. You know, the poster child for lack of trust is in the United States when we told people to not wear a mask. And then during COVID, we told people a mask would work. And the truth is that the reason we told people to not wear a mask was that we thought that COVID would behave like SARS number one, the first SARS virus, that it was something that you could transmit to somebody, but only after you were symptomatic. And so we didn't think that wearing a mask when you were asymptomatic would make a difference. And we had a mask shortage. So they were trying to preserve masks, particularly surgical masks, for the people that needed in high risk situations like hospitals, clinics, et cetera. And there was not a lot of studies that have been done on cloth masks. And of course, we didn't have enough of those N95 masks, which are the gold standard. We now know that masks were effective, that the N95 mask was most effective, the surgical mask was next most effective, that a multi-layer, tightly worn cloth mask was effective, and that not wearing a mask put you at greatest exposure. And you notice that I didn't say not wearing a mask didn't make a difference. I tried to share to you with the gradient of what happened from wearing a mask to not wearing a mask. And I think had we told people that, we would have made a difference and not lost trust, at least on masks. Now, having said that, the mask issue was highly politicized during COVID for a range of political benefit, which did not serve the public well. So poor communication, science evolving in real time, our understanding around masks, and politicization made a big difference.
All right, thank you. Next question. Given advances in genomic sequencing and wastewater surveillance, do you believe our current surveillance systems are capable of detecting novel pathogens early enough to meaningfully alter outbreak trajectories?
The technology is there to give us really early warning, particularly wastewater surveillance systems. Now, having said that, we haven't invested in those systems in every community. It's catch as catch can. And so we're going to have to put the money out to make sure that every community has the capacity to do that. There are some ethical rules around using it. And we need to have the ability to, once we find an outbreak or something that's concerning, to rapidly send that throughout our system. We still have many parts of the country where we can't even send an EKG, electrocardiogram, across the street. That's our problem. It's really a communications problem more than and a funding, a sustainable funding problem than it is, a surveillance system problem, or at least a knowledge based on the technology problem.
Okay. Um, to what extent can civil society organizations realistically compensate for reductions in governmental public health infrastructure without compromising surveillance coordination and response capacity?
Yeah, we can make a dent in it. We'll never have the funding, infrastructure, or legal authority to replace the federal government. Um, so, frankly, our strategy is to push back on the things the federal government is doing that we think um, are inappropriate and try to move them in a more positive direction. We're looking for ways we can work collaboratively with the administration, its current administration, and Congress, and then looking to build back better, so to speak, after this administration is gone.
All right, thank you. The next question is, oh, I'm planning on applying to PA school in April, and I'm wondering how beneficial do you think it might be to get a dual degree in public health and physician assistant studies? I'm very interested in learning more about public health.
So I'm laughing because my wife is a PA with an MPH and a doctorate in theology. She got her MPH and her PA from George Washington University. She got her PA first, and then she went back and got an MPH and had an amazing career. She's now retired, but she's worked for Johns Hopkins, Walter Reed, did research, did consulting, worked for the Institute of Medicine. She worked, actually came home one day and said, "Honey, I'm moving to Geneva." And she had a contract to go work for the World Health Organization. So she spent 10 months going around the world doing HIV/AIDS with WHO, and then came back and worked with the um, Association of Public Health Labs and ran their global health program for 5 years, and had a absolutely amazing time traveling all over the world, putting laboratories in resource poor countries. And everything I've learned about working in global health, I learned from her. So um, I can validate that it is a career that can take you far, and I wish you well in that because it is absolutely needed. The clinical part brings um, that white coat brings a great deal of credibility, whether you're a nurse or a PA, whatever. Particularly if you're going to go in a clinical setting. Um, doesn't take away from our friends who just have MPHs and doctors in public health, but that clinical piece adds another element to your portfolio.
Thank you. Next question. How did your public health training change slash impact the way you approach patient care? Or, and vice versa, how did your patient care impact the way you approach public health?
Yeah, so let me remind you, I don't have any public health training. You know, the CEO of the American Public Health Association has took epidemiology and statistics in medical school, but I really haven't gotten the credentials to say that I'm a real public health guy. I've got a couple honorary degrees that give me some credibility, and I guess 24 or almost 30 years doing this gives me some credibility. But I can tell you that it has the medical piece helped me understand what happens when you don't have prevention and wellness. The number of times that I saw where societal systems failed people, and that's why they had recurrent visits to the hospital when they didn't have adequate food, they didn't have adequate housing. We would patch them up, send them home, and they'd come back right back, sicker than they when we sent them out before. Um, I think public health has made me realize that policy drives optimal health. And I, there are many things in the emergency department that I could do. I could, if you crash your Chevy, I can put you back. I can get you to the orthopedist and the neurosurgeon, and they would do amazing things to save your life. But I can't take care of a little bit of high blood pressure, a little bit of diabetes, a little bit of cancer. I can't fix that in the ER, no matter how many times you come in. So if I can get you vaccinated, if I can get you screened for cancer, if I can get you to be accountable for your medications, take your medications as prescribed. If I can make sure you can afford your health care through policy, then I can do so much more than I could in the emergency department. Even though I miss emergency medicine each and every day, the truth of the matter is I influence more people's lives with a signed policy that gets properly implemented than I could ever do putting people together one by one.
Thank you. For students passionate about global and public health, are there particular organizations, internships, or experiences you recommend exploring?
Yeah, so I encourage people to do a bunch of things. First of all, there are internships out there all over the place. Even though the federal government has withdrawn some of the global health programs, Um, they're still out there. Dr. Google can tell you where they are because they're moving quickly. Some are paid, some are unpaid. And there are some prestigious ones in government, like the White House Fellowship, some of the congressional fellowships that even you should even do, even in this administration, because they're so prestigious once you get it. Um, I think that one should remember that you need to apply early for those, sometimes as much as a year early. You start January for most applications for the summer, because they're highly competitive, particularly the ones that have a salary associated with them. Um, you should be prepared to move for at least for the summer. Some are hybrid, and that's good. But I got to tell you, there's nothing like face to face. There's nothing like the water cooler stuff that you get by being involved in people. Now, here at the American Public Health Association, we do have internships. They are unpaid. If you go to our website, which is at apha.org, and then type in the search engine internships, you'll see our internship and fellowship page come up. um, Also, we have a career mart, which is free for job seekers. The employers pay. And there are jobs in that site that are important. We also on our website have some webinars to help you improve your resume and to help you think through the tools you need and the mechanisms to get the right buzzwords, since, as you know, a lot of jobs use search engines. And if you don't have the right words in your CV or the way you write your application, you won't be considered, even though you're highly qualified. In the old days, of course, you would send in a cover letter and a CV, and somebody would take a look at it. One tip, if you're still doing that, where someone asks you to mail in a resume with the cover letter, your cover letter often gets disassociated from your resume and your CV. So you need to make sure that your resume and CV includes everything that your cover letter says. Why you're seeking a job, why you're seeking the internship, should be right at the top. Yeah, they care you worked for the Cub Scouts or the Girl Scouts. They care where you went to school, um, but they want to know, they want to get the substance of who you are. And if you've done any volunteer work, if you've done any publishing, if you worked in a laboratory, those kinds of things give them a sense of who you are. Yeah, they care whether or not you're multilingual. That's important, particularly if you're looking for a job where speaking a language other than English is important. Um, and you can put that up front, multilingual individual, Spanish, French, English, seeking opportunity to do X, Y, Z, so that they see that right at the top. But it is important to understand that a lot of people write in a wonderful cover letter. It never makes it to the hiring authority, gets separated. So just know that that often happens.
Okay, thank you. What mindset do you recommend developing now to prepare us for the rigors of med school and onward?
Yeah. Um, med school is a lot of work, and you've got to be you've got to get as many skills as you can. Um, figure out I, figure out whether you're a visual learner or not. So I learned early in medical school I was a visual learner, and
Mm.
the medical school I went to, we saw patients our first year, and we got to spend time hanging out. And so for me, while I certainly read everything there was about diabetes, it wasn't until I went to the emergency department and actually saw my first case of diabetic ketoacidosis. Someone was about to die, and I actually saw how they managed that case acutely, that I was able to connect the dots. And so I discovered very early on, but it took me to medical school to figure out I was a visual learner. And so I've combined that. Second thing I think you want to do is get a good, a lot of kids spend a lot of time getting the pre-med courses. Those are important. But to the extent you get a balanced understanding of the sciences, the humanities, learn to write well, learn to write succinctly, learn to communicate well and succinctly, those skills will serve you very well, even if you decide to do pathology where you're not seeing patients.
Hmm. Okay, thank you. Uh, Next question. How concerned should we be that widespread prophylactic interventions such as antivirals or vaccines may unintentionally create evolutionary pressures that favor resistant pathogens?
Well, you know, I forgot which Surgeon General, but the 10th Surgeon General of the United States said that the era of pathogens was over, and we should pivot to chronic diseases. Um, I think we're now at the 24th U.S. Surgeon General. Um, I think it was Surgeon General Seward, if I remember correctly. Um, we have antibiotic resistance as a major public health problem today, and it's always going to be a problem. So yes, you articulated a very important problem. Um, but the solution to that, of course, is to prescribe the medications only when appropriate, make sure that we encourage patients to use the medications as prescribed, and we need to do the research to stay ahead of that evolutionary change of those bugs because they do change quickly. And we need to make sure that we don't do policy change that iatrogenically result in those kinds of antibiotic or antiviral resistance. For example, the effort right now to stop funding for HIV/AIDS treatment. When we stop PEPFAR, the global program to address HIV/AIDS globally, is going to result in antibiotic resistance or antiviral resistance of a virus that it took us years to figure out how to control. So we run a risk from a major policy decision, and in my mind, a, a fallacy that we shouldn't be helping the rest of the world because those bugs don't give a damn about what country you come from. They don't honor geographical boundaries. They don't honor airplanes or ships or whatever. They just lack the human body. And so it's a real problem. Um, so, yes, you're right. Evolutionary pressures are there, but they're always going to be there. We just have to figure out how to stay ahead of it.
All right, next question. How does the American Public Health Association collaborate with government agencies and communicates to improve health equity?
Yeah, we do it a lot. And as I mentioned, we continue with our health equity work. Um, we in our American Journal of Public Health, we published science. In that, we tell stories about health equity. We fight for funding, particularly for programs which we know are going to help address optimal health. We, through our legislative and advocacy efforts, we push for programs that are going to address equity, whether it's urban or rural, or race or gender. Need to point out again that race is a sociological construct and not a biological one. but it does serve as a surrogate for many things that we do. And we are very insistent that every time we think about who's in the room, who's not in the room, and how can we make sure we try to work to close those gaps between the various sectors of society who are at highest risk for disease.
How do
I'm
you,
gonna cut you off for a bit.
oh, for sure.
Dr. Benjamin, I had a question. I'm really interested in global health and like population level interventions. So, I was wondering how can public health systems really just shift more toward prevention rather than just reacting to crises, especially when funding and political priorities often focus on, like you said, emergencies.
Yeah, we just have to we have to keep insisting that they fund those programs. Um, Food and Drug Administration, for example, a lot of money for drugs. In fact, there's the private sector actually helps fund a lot of the work of the FDA, but they don't have that same authority in the FDA for foods. So you see that the current health secretary, Mr. Kennedy, is very critical of the FDA's work on foods. And the truth of the matter is, had he and others been spending their time advocating for more funding for the food program, we would have been able to do a lot of the research that he would have loved to have done, that we all agree ought to be done. So that's an important point that we have to insist on funding. Every state in this country does not have a comprehensive chronic disease program in their health department. They don't even all have a chronic comprehensive anti-diabetes program or anti-hypertension program. Um, we have, for a variety of political reasons, not put in firearm safety programs in every health department in the country. We have not put in programs to address the leading cause of injury for adults, which is falls. And we really haven't done the kind of research that's necessary to figure out why people fall. By the way, a lot of it's medication induced and a lot of it's gait induced, but we just haven't played for that. So, Alzheimer's disease, major problem, but the research for that, there's been some advances, but not nearly enough to to address it going forward. So, policy is where you put your money, and personnel is policy. So you need to put people in place that know what they're doing, that have skill and expertise in doing it, and you need to fund it um, adequately to get the results that you want.
Yeah, thank you. That's really interesting. Do you think that those prevention strategies you mentioned could also translate well into global health systems, especially in lower resource settings?
Oh, absolutely. And the more interesting thing is the lower research setting um, always come up with innovative ways to do things that could be imported here in the United States. Excuse me, but for a variety of reasons, we don't do it because they weren't developed by us. And there's kind of an elitism, an American exceptionalism concept that we have that where we don't use the amazing techniques and tools that are developed in other countries here. Um, Home visiting programs in places that have universal health care, where have system with everybody in, everybody out. Many of those programs, no matter what your income level is, they send a nurse in the home after delivery to make sure, particularly for that first pregnancy, that they promote breastfeeding, that they make sure the woman knows how to properly breastfeed, that their significant other is there to help them, that the home is designed and resourced for the new baby. And if not, they bring in social services to provide support. Um, we have um, a range of social supports in those countries that are very important that if implemented here in the United States, and we kind of do them on pilot programs, we would have an enormous improvement in our health.
Thank you.
Okay, well, do you have any tips on how to develop these skills for public health, like such as being a regulators or anything like that?
Yeah, we should be trained. We should be taught to do that. I mean, it should be part of the regulatory program. You get an MPH, um, you should be able to take a good course in how to be a regulator. Now, look, you know, public health, getting a master's in public health used to be the degree. It was kind of the MBA for doctors. Many years ago, physicians got a MPH as a way of teaching them the skills they didn't get in medical school. It were five core courses: epidemiology, environmental health, statistics, health administration, and mental health. And those were viewed as the five things that were most deficient in basic medical education. Um, so it then allowed other people to get a graduate degree in public health. So nurses began to get MPHs. People then begin to get MPHs without any clinical background at all. Um, and now we started with undergraduate training in public health. So now, if you start looking at how you articulate all of that together, I would ideal that one ideal pathway could be getting an undergraduate degree with a major in public health or a minor in public health, then going to get a graduate degree in public health with more specialized training, and then maybe even going on, should you want to, getting a doctorate, either to do research or because you want to do policy. Because what happens right now, a person gets an undergraduate degree and whatever undergraduate degree they want, and that's fine. And then they go to get their MPH, and it's a 2-year program. And we make people specialize, in my view, way too soon. They decide they want to do global health or injury or MCH, or some kind of quantitative degree. And there are opportunities now for us to give people a much more spread out spectrum of training. The other thing we can do is postgraduate school developing a range of relatively short courses um, in regulatory science, in advocacy, in political skills, um, enhanced data skills, um, advanced statistical skills. And those kind of exist, but not in an organized way. And in fact, my organization is looking right now as how we can build an ongoing skills development program to try to provide those, um, for people as they advance in their career. And of course, in medicine, we have that, right? You do an internship, a residency, a fellowship, and then, of course, continuing medical education courses, both short courses and long courses. We need to do more of that in public health.
Okay. How concerned are public health leaders about the long-term erosion of public health workforce, of the public health workforce, particularly in epidemiology and field investigation roles?
Yeah, we are extraordinarily short in certain specialties. So first of all, we're short everything, but particularly epidemiologists. There are health departments in this country that do not have an epidemiologist assigned to them. We have over 3,000 health departments in this country, and about a quarter of them don't have any health epidemiology support in the department. They may get it from the state, but there's still a big shortage of epidemiologists. Um, Statistical skills. There are a lot of people that don't have the statistical skills that they need, even the basic ones, because a lot of people come into public health like I did. They come from the clinical side of the house, and then on Friday and on Monday, they're in charge. They're running a program. Um, their statistical skills were back when they were in either undergraduate school or if they were in med school or nursing school, that's where they got them. Um, and now they're running a program, and they're now having to, as the manager, they don't need very detailed statistical school skills, but they need to know what a p-value is, and they need to be able to talk about inferences, and they need to know what R naught is for infectious diseases. And those are not things that they're facile with on an ongoing basis. So we also have to have a more robust skills development program for people who are coming without core public health training to make sure that they can enhance their ability to be a supervisor of people with that really detailed knowledge. Because when my staff would bring me something, I have to be able to ask, I have to know what questions to ask them and to make sure that they haven't forgotten something and that the information we're putting out is validated and creditable.
My next question is, what parts of being a physician still excite you most after all these years?
I still get excited when I get presented cases either in the journals or someone's telling me a story of a case that they can't figure out what the diagnosis is. I actually was a pretty decent diagnostician in my day, and so I still enjoy the um, the differential diagnosis uh, of disease. Um, my emergency medicine and my interest in very sick patients. If you're walking around me and you twist your ankle, I get real excited, want to help you. Uh, I really value primary care. There's no question about primary care being very important, but I'm a patient's about to die kind of person. I really still get turned on by the ability to really help someone who's very, very, very sick. And, I still read all the emergency medicine literature and I'm very involved with that. And the other thing is that I have spent a fair amount of my career kind of thinking through emergency medicine and thinking of disaster medicine and terrorism. And unfortunately, the terrible things that people intentionally do to one another is an area which I have developed a relatively reasonable expertise. And I still dabble in that area whenever I can find the time to do so.
Uh, if another pandemic scale pathogen emerged, what part of the US public health infrastructures would become the primary bottleneck? Laboratory capacity, surveillance data integration, hospital surge capacity, or public communication?
Boy, that's a good question. I don't know that I have a great answer for you because all of those are weak. Um, you know, the goal for a public health practitioner is to figure out as soon as possible when a new health threat enters the community. And you notice I said threat. That means you have a bunch of people that got sick, and your goal is to first go in and find out whether or not that's a threat. Those people are sick. You already know they're sick. The question is, what is the threat to the broader community? And is this something that, if it is a threat to the broader community, how easy it is to contain? So I remember once as a health officer in Maryland, we had a 750 person foodborne outbreak. And this was before 9/11 and the anthrax letters. And we were on high alert just because there was a lot of attention to potential for terrorism in the country. And it turned out that it was a festival where people were coming down in Southern Maryland and buying hams. And it was a very famous thing that happened down in Southern Maryland every year. And frankly, they just hadn't cooled the hams properly. So the threat was limited. Tragically, a lot of people got sick, but the broader community was not at risk. Fast forward 9/11, and then a month after 9/11, when a guy started sending letters around the country with anthrax powder, and nobody thought that anyone could weaponize anthrax that wasn't a state actor. You may know it turned out to be one of the US's actual bioterrorism scientists that did it. But our assumption was that it would be very difficult for anyone other than maybe Russia, maybe China, um, to countries that had bioweapons programs to make the good stuff. Turned out this guy made the good stuff, and we spent months chasing that outbreak. So, and by the way, it was picked up by an astute clinician, first as skin lesions, and then later as the first person who died with inhalation anthrax in Florida. An astute clinician picked that up, and we were off to the races. The second big one was the Ebola outbreak that we had. It was in Africa. We knew it was coming, and we had on high alert. But it did get here, and we put in place a lot of stuff. But the resources that we invested in to have to address that were enormous. And then as soon as we thought we had our hands around it, all the money went away. So we didn't maintain our readiness. And that's the biggest threat I think we have in the country is the lack of maintenance of readiness throughout the system.
In your opinion, what are some of the biggest improvements you think are still needed in the U.S. public health infrastructure to better prepare for the next major health emergency?
Don't say that again.
In your opinion, what do you think is a major improvement that can be made to the U.S. public health infrastructure to better prepare for the next major health emergency?
I think the most important thing we could do for health, period, would be to build a national health information technology highway. That means making sure there's no community that has Wi-Fi deserts. That makes sure that we build on the infrastructure that we have on the internet already to share data rapidly. That we have the ability to share information in a where it needs to be confidential, confidential, where it doesn't need to be, doesn't need to be, so that we can validate it. So you will ask, is that possible? Well, first of all, there's a national experience in actually doing that kind of thing. The national highway system under President Eisenhower, that time we had this disjointed group of roads, federal highways, federal roads, local roads. They didn't go anywhere, roads to nowhere. And Congress got together with the president, put in place a system, funded it, and we have the national highway system today. And they built it theoretically under national security for us to be able to evacuate our cities under a nuclear attack. And I'm not quite sure in today's world you can actually evacuate a city, but that was the plan. But it built us a national highway system. Right now, there are countries in this world that actually have such a system. Taiwan, for example, I remember sitting in the Taiwanese CDC during a dengue outbreak, watching real time clinicians diagnosing dengue and them popping up on a map in the CDC of Taiwan. And then when they got a cluster, they would send a mosquito control group to that community to tamp down mosquitoes. Okay. Um, can we do this in this country right now? Does anything exist? I would commend you to your cell phone and DoorDash and Uber and your bank. All of them have a national information sharing system, and they all share systems and data across those systems in a confidential manner. But again, we cannot send an EKG across the street. I'll tell you one other personal quick story. I had my hips, I've had both my hips replaced. And I love to tell this story. So my second hip replacement, my first hip replacement, we worked out my post-surgical PT real well. I did inpatient rehab for 10 days, and then I went to a different provider who was affiliated with my orthopedic group for my outpatient rehab. We plan to do the same thing for my second hip. It's just that we hadn't set up the outpatient before I had surgery. We just didn't do it. We had a heck of a time. In fact, the bottom line was I had to be discharged before I could actually make that happen. And that was me getting on the phone and making it happen. The social worker who was supposed to help me do that just couldn't make that happen. However, my cat was in the kennel. My cat ran out of cat food. I picked up my phone. I ordered cat food. I watched the cat food. The DoorDash guy go to the store to buy the cat food. I watched it get delivered to the kennel. I got a call from the kennel to let me know that my cat food had arrived. And I got a call from the Uber driver, DoorDash guy, I guess, because he likes cats and he wanted to make sure that I knew the cat food had been delivered. But I couldn't get my appointment done for my hips. Tell me why that doesn't make any sense. And I know the system. Imagine someone who's not literate in taking care of their health care, trying to manage that.
Okay. Final question. Are there particular classes of pathogen such as zoonotic virus, antimicrobial resistant bacteria, or vector-borne diseases for which our surveillance system remains significantly underdeveloped?
We can pick up it. It's more important to pick up clusters of sick people and then going in doing the investigation to figure out what the disease process is. So we have surveillance systems called syndromic surveillance systems where we pick up people who are just sick. People, number of people going to the ER is outside of our norm. Number of school absentees on a particular day. You crosswalk those two pieces of data sets. So to the extent that you can do public health surveillance, and it's called in public health intelligence surveillance systems, where you take these various systems, you crosswalk them at a fusion system where you look at absentee data, number of cold medications coming off the stores in a store when you get a peak, and then hospital visits. You can crosswalk those three things, tells you something bad is going on in the community, and then you go in and do the case finding and figure out what it is. Um, and by the way, common things occur commonly, and we're much more likely to have a big outbreak from a common disease than we have for something unusual. Um, emerging Emerging diseases rarely hit us, but common things occur commonly, which is why they're common.
Thank you, Dr. Benjamin. Oh, thank you. Um, yeah, I think those were all the questions. I hand it back off to Manasvi.
Oh yeah, thank you so much for your presentation, Dr. Benjamin. I actually had three more questions. Oh, two more questions in the chat. So, what lessons from recent public health crises should shape how we prepare for the next global emergency?
Yeah, I think one of the more important things that we do is that every administration, regardless of party, um, takes apart the biopreparedness activity in the National Security Council and then finds out, oops, we need that. We need to set up a mechanism nationally with a national infectious disease coordinator, in fact, to address public health emergencies. And we need to make sure that's permanent um, so that we don't have to keep reinventing the wheel. Um, Health emergencies kind of creep up on you. They're not like hurricanes and tornadoes where boom, they happen and FEMA knows what to do. We Health emergencies are much different. They tend to get handled at the local level. They tend to rise up and all of a sudden we find ourselves chasing the outbreak. And so we need to jump on any outbreak very quickly, being coordinated at the national level in a much more effective way.
Yes, thank you for that. And for any high schoolers on call, what experiences or opportunities would you recommend for high school students who would want to work in public health or health policy in the future?
I think checking with their local health department because it's in their neighborhood. There's a health department in the neighborhood, and either volunteer there or if they have an internship there, try to do that. Do shadowing, shadow the health officer or the epidemiologist in your community if there is one, just so you get a sense of what it is, what their day looks like. Um, my day is sitting around a desk doing a lot of stuff and going around making speeches and reading a lot of stuff. But the folks that are out there in the front line have really interesting and exciting things, and every day is different. Enjoy it, have fun.
Okay, yeah, that was it for this session. I'll do a quick wrap-up presentation and people can stay back if they have any final questions. But thank you for your presentation, Dr. Benjamin. Okay, so I have three reflection questions for everybody, which is what were your favorite moments or examples from today's session? What's one idea from today that you're most excited to explore next? And what's one key takeaway or idea that stood out to you the most? Feel free to answer these questions in the course reflection on the website. Other than this, you can also feel free to share your insights on LinkedIn. LinkedIn's a good professional platform where you can add your insights, and it would be really cool for PHS. And you can tag us at Pre-Health Shadowing. And once again, if you're interested in being part of the Pre-Health Shadowing team, you can do so by registering for our website, which is 100% remote. You can also apply for a leadership team. And once again, if you can, please consider donating because we run solely off the time and donations of our volunteers. So we would be really grateful for that. Don't forget to take the digital course certification after this session, and it is based on the 10-question multiple choice quiz, which was based on today's session. So I hope you took good notes, and it's also linked in the chat. And if you missed part of the session today, you don't have to worry. You can check out our YouTube prehealthshadowing.com website and channel and just watch any of our previous sessions for free. Make sure you sign up for our newsletter and check on any new live sessions on the PHS website. And thank you so much.
Bye bye, everybody.
Yeah, thank you, Dr. Benjamin. Thank you, everybody. Okay, does anyone have any final questions? Okay, I'm guessing that's no. Thank you guys. Thank you, volunteers. It was a great session. See you guys.